So this is a summary of the lecture on the 15th of February. So what we first discussed was this study by Bev Ulrich and Dale Ulrich looking at Down syndrome, children with Down syndrome, looking at trying to improve their gait acutely. Remember, children with Down syndrome have delayed onset of gait. One of the reasons for this is that their ligaments are very loose, their pelvic girdle is very floppy, and that's, for example, why you should always test the neck ligaments, transverse ligaments in people with Down syndrome before you consider doing any manipulations or mobilizations of a cervical spine. Anyway, that's beside the point. So this experiment here was looked at children with Down syndrome walking on a treadmill before they can walk by themselves. So they're suspended over the treadmill like that cat experiment by a parent, and they're lowered onto the treadmill and their feet are moved by the treadmill just like the cat was. So this is their baseline chart here, or graph. This bar here shows how many reciprocal steps the child, the baby, the infant took in, I can't remember, it was a minute, I can't remember the time on here, but anyway, so up is good. The number of reciprocal steps per given a unit of time, baseline measurement. So this is bare treadmill, no manipulation, no adjustments of constraints. So that's about 11 steps. On the Velcro situation, they put the infants in socks and put Velcro on the bottom of the socks, stitched to the socks, and they had a little bit of carpet on the treadmill. So that carpet increased the friction between the foot and the surface of support by this Velcro carpet interface. So the feet were then moved backwards more by increased friction between the surface of support, by the Velcro obviously, and the foot would, break off eventually and swing forward. So you can see a massive increase in stepping when you increase the friction between the foot and the floor of the treadmill. The knobbly surface, here the treadmill had little rubber knobs on them, and this Bev thought made the treadmill kind of ticklish, and so the feet would be lifted up and down quickly as the baby put their foot down onto the treadmill. Again, increased stepping rate. The girdle situation here, they increased core stability, the pelvic stability of the child by putting a big belt around the pelvis and cinching it in, so gave the pelvic girdle more stability. Remember, with Down syndrome, those ligaments are going to be very lax, and so they naturally have less stability in the pelvic girdle. And this increased the pelvic girdle stability and resulted in more steps. And the weights condition, they added little ankle cuff weights to the kids' feet around their ankles, and that increased the pendular action of the foot, and so they were swinging more forward using the gravity to move the sort of leg like a pendulum. Each time the leg was dragged back by the treadmill, the pendular action would swing the foot forward, and you see again a big increase in stepping. So I'm using this experiment as an example, perhaps, or the illustration of how you can manipulate constraints and improve the motor performance you're looking at. This was not done chronically. We don't know if they trained to do this with these conditions for a few weeks, would that allow early onset of gait? We don't know that, but I suspect it would. This is just 1 day's worth of practice shown in this experiment. Again, so constraints can change motor behavior. We should be thinking about how can we adjust constraints in our treatment to get the more desired motor behavior that we're looking for in our patients. I talked about bodyweight supported treadmill training as a way to manipulate constraints to allow more normal gait, and there's a whole series of experiments been looked at this in various diseases, and it's shown to be very powerful. So when the patient is in this harness suspended over the treadmill, you remove obviously the constraint of fear because they can't fall anymore. you remove the constraint of force being a limiting factor. Muscle force generation does not have to be as great if the body weight is being taken, so you don't have to push off as hard with the legs. Postural balance issues. The patient's not going to fall here, so they don't have to have sufficient postural support to be able to walk over ground, because here they can use the harness for that postural support, that balance. They're never going to fall with this system. So it's removing some of those constraints that, for example, in an infant, you would see that would prevent normal gait from emerging. So postural control, fear, etc., is not a rate limiter using a bodyweight support treadmill training system. So that's one of the reasons I interpret that bodyweight support treadmill training can improve gait in many clinical populations. This experiment sort of cast a bit of doubt, but this was also sort of came out examining bodyweight support treadmill training. And what they basically found was you don't really need to have a bodyweight support treadmill training system to get big improvements in gait ability in patients. So what they did here, they looked at home exercise program by a physical therapist, looking at to improve walking, and compared that to a bodyweight support treadmill training system. And they found that there's actual equivalent gains in their walking with bodyweight support treadmill training and a intensive home health exercise program. The other point they made in the first sentence here is that people continue to improve their gait up to 1 year after stroke. Some people think that your recovery from a stroke occurs early and basically plateaus and basically stops after 6 months. And so after 6 months, you've basically got all you're going to get, and that you may as well give up therapy, which is really silly, because as this experiment has shown, and many others, well, some work I've done has shown that you can have significant improvements in motor behavior way after a year. And I mentioned that one lady I had for 12 years post-stroke, and she made significant improvements in her hand function as a result of constraint-induced movement therapy. Speaking of constraint-induced movement therapy, I talked about how I don't confuse the word constraint in constraint-induced movement therapy with the notion of constraints from a dynamic systems perspective. The dynamic systems perspective are looking at organism, environment, and task as levels of constraint, and how the task emerges out of those three constraints. This is a totally different use of the word constraint. This is actually a physical constraint put on the limb to force the bad arm to start moving again and relearn how to make some of these skills. So we're trying to get away from learned non-use. Basically, use it or lose it. If you don't use your hand, the brain space devoted to that hand is going to shrink. I mentioned some experiments looking at violinists. The bowing hand has much less representation in the contralateral cortex as the fingering hand that has much more fine manipulative skill requirements. You'll see the finger space on the motor cortex on the contralateral hand much bigger than if the hand was just bowing, using the bow to go back and forth across the violin. You remove the thumb of a monkey, the motor cortex devoted to that thumb in the contralateral cortex disappears, and it's invaded, it's taken over by the fingers. The fingers sort of now gain more motor cortex. So the take-home message is use it or lose it. The brain is plastic. Force the patient to use that involved limb more and more and more, and the more you can use it, the more changes will take place in the brain, plastic changes, and hopefully that you'll get significant improvement in that hand. I also mentioned that, a lot of research has shown that intensity of practice is really important. The intensity of practice is going to give you your best result. It's not just a couple of minutes a day, half an hour a day, or half an hour using the hand once a week or twice a week in therapy. You've got to really, really, really force them to use that hand as much as they possibly can. And one way of doing it is by putting a oven mitten or something like this over the good hand to sort of remind them to use the bad hand as much as they possibly can. And finally, this side just gave it some references. If you're going to use constraint-induced movement therapy in your treatment when you get out there, these last two are really good references to read to try to come up with a plan for using that. This first paper just showed that after a couple of weeks of constraint-induced movement therapy in children, you saw actually gray matter changes. The volume of gray matter devoted to that hand was increasing. They actually did brain scans and found physical changes in neurons, and as a result of constraint-induced movement therapy. So something I'll definitely encourage you looking at when you start your clinical practice. All right, so then we moved on to